This lecture will go over pulmonary embolism, which is on page 616 of chapter 32. So pulmonary embolism is a collection of particulate matter, solids, liquid, or air that enters venous circulation and lodges in the pulmonary vessels. Large emboli obstruct pulmonary blood flow, leading to reduced gas exchange, reduced oxygenation, pulmonary tissue hypoxia, decreased perfusion, and potential death. Any substance can cause an embolism, but a blood clot is the most common. The diagram on the video there shows a pulmonary embolism with infarction. Again, collection of particulate matter, whether solids, liquid, or air, enters the venous circulation and lodges in the pulmonary vessels. Usually it's a blood clot from a venous thromboembolism in the leg or pelvic vein that breaks off and travels through the vena cava into the right side of the heart and then passes into the lungs. Once the clot lodges in the pulmonary artery or within one or more of its branches, platelets collect on the embolus, triggering the release of substances that cause blood vessel constriction. Widespread pulmonary vessel constriction and pulmonary hypertension impair gas exchange and tissue perfusion. Deoxygenated blood moves into arterial circulation, causing hypoxemia, although some patients with PE do not experience hypoxemia. Major risk factors for VTE that lead to PE include prolonged immobility, central venous catheters, surgery, obesity, advanced age, conditions that increase blood clotting, and a history of thromboembolism. Smoking, pregnancy, estrogen therapy, heart failure, stroke, cancer, and trauma increase the risk for VTE and PE. Chart 32-1 on page 617 goes over patient teaching for preventing a pulmonary embolism. Please review that on your own and be familiar with those patient teaching strategies. Under health promotion and maintenance, although pulmonary embolism can occur in healthy people without warning, certain conditions increase the risk for occurrence. Lifestyle changes help to reduce the risk for PE. Tobacco narrows blood vessels and increases the risk for clot formation, so smoking cessation is encouraged in all patients. Urge patients to stop smoking cigarettes, especially women who use hormone-based contraceptives. Reducing weight and becoming more physically active can reduce the risk for PE. Teach patients who are traveling for long periods to drink plenty of water, change positions often, avoid crossing their legs, and to get up from the seated position at least 5 minutes out of every hour to prevent stasis and clot formation. For patients who are known to be at risk for PE, small doses of heparin or low molecular weight heparin, known as enoxaparin, can be prescribed. Oral direct thrombin inhibitors may also be prescribed. For adults who have ongoing risk for VTE and PE, prevention may include pre-op placement of a retrievable inferior vena cava filter. This placement occurs before any surgery, in which the patient is expected to be confined to bed for more than just a few days and is retrieved when the patient is fully ambulatory. In terms of interprofessional collaboration, a lot of different people are going to be assisting this patient. The patient will most likely have a pulmonary healthcare provider in addition to the primary healthcare provider. The pulmonary healthcare provider is needed for continued assessment and management of reduced lung function. Respiratory therapy will be on board for oxygen therapy and treatment. PT and OT likely to be on board also to help maintain muscle conditioning and provide information about any modifications needed for home for when the patient is discharged home. Registered dietitians assess patients' caloric and protein and nutritional needs and make interventions as needed. Pastoral care workers and clergy may be able to assist the patient who is experiencing spiritual distress. And social workers, together with home care and nurses, determine what type of home modifications and supplies are needed at the time of discharge. In terms of assessment, signs and symptoms range from vague, nonspecific discomforts to hemodynamic collapse and death. It is important to remember that many patients with PE do not have classic symptoms. And if you look at chart 32-2, the key features, classic symptoms include dyspnea with a sudden onset. And that's an important thing to remember with PE, it'd be a sudden onset, right? The clot travels, all of a sudden gets lodged, and the patient experiences a sudden onset of dyspnea. Sharp stabbing chest pain, apprehension and restlessness, feeling of impending doom, cough, and hemoptysis are included in those classic symptoms of pulmonary embolism. If we go back down, breath sounds could be normal, or they could include cracks, wheezes, or a pleural friction rub. A dry or productive cough may be present. Hemoptysis may result from pulmonary infarction. Assess the patient for difficulty breathing, dyspnea, and pleuritic chest pain, sharp stabbing type pain on inspiration. Cardiac symptoms can be related to decreased tissue perfusion and include tachycardia, distended neck veins, syncope, cyanosis, and hypotension. Systemic hypotension results from acute pulmonary hypertension and reduced blood flow. Abnormal heart sounds may occur, and ECG changes may also occur. Other signs listed under chart 32-2 include diaphoresis, fever, a low-grade fever, petechia over chest and axillae, and decreased arterial oxygen saturation. You have a yellow box there. Monitor patients at risk to recognize signs and symptoms of PE, including shortness of breath, chest pain, and or hypotension without an obvious cause. If such symptoms are present, respond by notifying the rapid response team. If PE is strongly suspected, prompt categorization and management strategies are started before diagnostic studies have been completed. Symptoms of PE often occur abruptly and the patient can be anxious. Hypoxemia may stimulate that sense of impending doom and cause increased restlessness in the patient. Laboratory assessment, the hyperventilation triggered by hypoxia and pain first leads to respiratory alkalosis. The PaO2-FiO2 ratio falls as a result of shunting of blood from the right side of the heart to the left without picking up oxygen from the lungs. Shunting causes the PaCO2 to rise, resulting in respiratory acidosis. Later, metabolic acidosis results from the buildup of lactic acid caused by tissue hypoxia. Even if ABG studies and pulse oximetry show hypoxemia, these results alone are not sufficient for a diagnosis of PE. A patient with a small embolus may not be hypoxic, and the PE is not the only cause of hypoxemia. Labs to look at include the D-dimer value. The D-dimer, a fibrin split product, rises with fibrinolysis. When the value is normal or low, it can rule out PE. If the value is high, other diagnostic tests would be needed to determine whether PE has occurred. So basically, D-dimer being high can occur with any sort of clots being in the body. So you might have a patient who had surgery within the last week, and now we're thinking maybe they have a PE and their D-dimer is kind of high. Well, they just had surgery, so it's not going to be a definitive diagnosis of a PE because the D-dimer is high, because it might be related to the surgery or something else that the patient has going on. But an elevated D-dimer would cause the provider to continue looking and try to continue looking to see if it is indeed a pulmonary embolism that the patient is suffering from. Other ways to assess for pulmonary embolism include pulmonary angiography and a CT. A chest x-ray may diagnose other conditions that mimic acute pulmonary embolism. Doppler ultrasound may be used to document the presence of a VTE and to support the diagnosis of a PE. So my priority problems in my patient with a PE include hypoxemia, hypotension, potential for excessive bleeding, and anxiety. Under planning and implementation, responding. When a patient has a sudden onset of dyspnea and chest pain, immediately notify the rapid response team. Reassure the patient, elevate the head of the bed, prepare for oxygen therapy and blood gas analysis, while continuing to monitor and assessing for other changes. Under planning expected outcomes, the patient with PE is expected to have adequate tissue perfusion in all major organs. We were hoping for ABGs to be within normal limits, pulse ox to be above 92%, cognitive status unimpaired compared with baseline, and the absence of pallor and cyanosis. In terms of interventions, non-surgical management of PE is most common. Management activities for PE focus on increasing gas exchange and oxygenation, improving lung perfusion, reducing the risk for further clot formation, and preventing complications. Priority nursing interventions include implementing oxygen therapy, administering anticoagulation or fibrinolytic therapy to improve tissue perfusion, monitoring the patient's response to interventions, and providing psychosocial report. On page 619, you have a chart 32-3 that's about the care of the patient with a pulmonary embolism. In terms of oxygen therapy, we're going to monitor pulse ox, monitor ABG values to keep track of the patient's status. Mechanical ventilation may be needed in some patients. We're going to monitor the patient continuously for any change in status, monitoring vital signs, lung sounds, cardiac and respiratory status at least every 1 to 2 hours. Document increasing dyspnea, dysrhythmias, distended neck veins, and pedal or sacral edema. Assess for crackles or other abnormal lung sounds along with cyanosis of the lips, conjunctiva, oral mucosa, or nail beds. Drug therapy begins immediately with anticoagulants to prevent embolus enlargement and more clotting. You have on page 621, chart 32-4, a list of common drugs used to treat pulmonary embolism. So heparin, under heparin, you have heparin sodium and enoxaparin. Under vitamin K antagonist, you have warfarin. And then under fibrinolytics, you have alteplase or TPA. So I want you to be familiar with those medications and how they work. And then if you also turn the page one more page to 622, you have blood tests used to monitor anticoagulation therapy. And I want you to be familiar with those blood tests too, what they're looking at. So they're monitoring clotting and bleeding times. For INRs, it states that the therapeutic range of INR for PE is 2.5 to 3. I just want you as students to know that the basic goal INR is 2 to 3, and that with certain conditions, the physician might want a different level of INR. In this case, it says PE 2.5 to 3. I'm not worried about you knowing the different nuances and what the physician might be asking for, because I just think it's going to be too much. I want you to know in general, the goal INR is 2 to 3, but I want you to understand in clinical practice that you might need to check orders and see exactly where the physician wants that INR to be. Page 620 under that pink box also lists antidotes. You need to be familiar with the antidotes for the medications that we're using. These are high-risk drugs, so we need to be familiar with the antidotes that can be used for those. Under surgical management, an embolectomy would be a surgical removal of the embolus. Inferior vena cava filtration, you have a video you can watch that goes over that. Under managing hypotension, IV fluid therapy, crystalloid solutions can be used to restore plasma volume and prevent shock. Drug therapy with vasopressors is used when hypotension persists despite fluid resuscitation. Vasodilators can be used to decrease pulmonary artery pressure if it is impeding cardiac contractility. Under minimizing bleeding, priority nursing actions are ensuring that appropriate antidotes are present on the nursing unit, protecting the patient from situations that could lead to bleeding, ensuring correct drug therapy, assessing lab values, and monitoring the amount of bleeding that occurs. Assess for evidence of bleeding, examine all stool, urine, drainage, and vomit for gross blood or occult blood, measure the patient's abdominal girth every 8 hours, as increasing girth can indicate internal bleeding. If the patient has severe blood loss, packed red blood cells may be prescribed. I'm going to let you look at minimizing anxiety and the rest of that information regarding PEs. Please pay special attention to the boxes also that accompany those final pages of pulmonary embolism.